Right. Hello, everyone. We are very excited to welcome you to our next webinar from the Drexel CCUH, the Climate Change and Urban Health Center. We are very excited today to have Dr. Stefanie Ebelt here to join us to talk about climate-sensitive hazards and health risks in urban populations, lessons from the South. So Dr. Ebelt is a professor of environmental health and epidemiology at Emory University's Rollins School of Public Health, excellent School of Public Health, with a research focus on air pollution, climate, and human health. Her work investigates changing air pollution mixtures and climate-sensitive health risks across populations, guided by the goal of translating research to action. She co-leads the research core of Emory's Climate and Health Actionable Research and Translation, or CHART Center, and is currently an editor at Epidemiology, the journal, and former vice chair of the Gangarosa Department of Environmental Health. Two quick reminders before we get started. First, we have interpretation to Spanish and Portuguese available, live interpretation. So please select the interpretation icon in your Zoom screen to activate that. And secondly, please use the Q&A button to submit questions throughout the presentation, and we'll answer them at the end. So please join me in welcoming Dr. Ebelt.
Well, thanks so much for the introduction. Can you all hear me?
Yep.
Yes.
Good.
Okay, great. Yes, thanks so much for having me join you today in your webinar series. And thanks for the introduction. I'm excited to share with you some of the work that we're doing at Emory on climate and health, and not sure so much about the lessons from the South, but at least maybe the goal here is to kind of show you some of the work that we're doing and some kind of overarching directions and thoughts on that. Let me just see about clicking forward here. So just in terms of my background, so you know where I'm coming from, I grew up in Vancouver, Canada, and also did my undergraduate and master's in occupational hygiene at the University of British Columbia. And from there, I went over to the School of Public Health at Harvard to do my doctoral work in environmental health, and then have been at Emory in Atlanta since 2005. So I guess I've just marked my 20-year anniversary at Emory, which is really kind of crazy to think about. Time flies in some ways. So in terms of this presentation, this may not be that new to you, but I'll give some background on air pollution, climate, and health, just to help motivate some of the work that I'm working on with my group at Emory. I'll do a quick overview of my overarching research goals, and then I'll show some selected work on air pollution and asthma, because I do come kind of from the air pollution field. So I'll include some of that work, but then also work on heat and heat-related morbidity that we're working quite intently on at Emory. And the selected work is framed within the context of two key research projects, the acronyms for which are Envision and CHART, CHART being our P20 Climate and Health Center. And so I'll spend some time setting up both of these projects, focus a little bit more on the overarching setup with some selected results. So in terms of air pollution, we know that air pollution is comprised of a mixture of both gaseous pollutants such as sulfur dioxide, nitrogen oxides, volatile organic compounds, carbon monoxide, as well as particulate pollutants such as particulate matter or pollen and mold that are also in the air. And these arise from a variety of sources that we might consider both natural sources, so things that happen on and around the world naturally, but also through our human activities that are more anthropogenic sources from industry, energy production, transportation, and agriculture. And so these sources all emit these pollutants into our atmosphere. And some pollutants, such as ozone, are not emitted directly by any of these sources, but are created by the atmospheric reactions of nitrogen oxides and organic compounds through the reaction of sunlight and warm temperatures to create ozone. We've seen a lot of air quality successes over the last 30 to 40 years, largely in the US through our national ambient air quality standards. We've seen enormous reduction of emissions of the key kind of criteria or regulated pollutants since 1970, despite a considerable economic growth that we might measure in various metrics like gross domestic product or vehicle miles traveled. And with that significant reduction in emissions, we've also seen a great improvement in air quality. We also know that from ongoing epidemiologic studies, we see that despite reductions in pollution from policies, we continue to see associations between, for example, mortality and long-term exposure to PM 2.5 and other pollutants, even at concentrations below our current standards. And globally, the Global Burden of Disease Project has ranked air pollution as the second largest risk factor for deaths in 2021, just below high blood pressure, with a large proportion of this mortality being attributed to outdoor air pollution or outdoor PM 2.5. Moreover, in addition to mortality, we also know that air pollution also affects morbidity in terms of a variety of different outcomes. As in inhalation exposure, we know that it impacts the respiratory system, and through the both local but then also systemic oxidative stress and inflammatory processes invoked by air pollution, we see cardiovascular outcomes, reproductive outcomes, and also a growing literature showing impacts on brain health, including cognitive decline. So overall, air pollution, we know, impacts quality of life in a variety of ways, has economic impacts, and also a concern that just short-term health effects might accumulate over time to contribute to long-term health consequences. Air pollution, of course, is intricately linked with climate. We know that sources of air pollution and health-relevant pollutants that we're concerned about today, these sources also emit carbon dioxide and other greenhouse gases that over the long term have been linked to increasing global temperature. The latest data show that 2023 was the warmest year on record, with average global temperatures about 2 degrees Fahrenheit higher than the 20th century average. This, on average across the globe, doesn't sound like a big increase in temperature, but we know that these increases in temperature globally have pretty significant local impacts on weather and air-related factors, such as an increasing frequency and severity of extreme heat and heat waves. Ozone, as I'd said before, is a climate-driven pollutant in that it is created under the circumstances of sunlight and warm temperatures with the reactions of other pollutants. We know that rising global temperatures are increasing the risks of drought and thereby increasing risks of dust storms and impacting air quality in certain regions, including in the southwestern US. Similar drought-related impacts on wildfires that we're seeing in the West, a changing landscape on pollen exposures, as well as other impacts on broadly air quality through storms and severe weather that are implicating public health. So my overarching research goals are kind of motivated by this kind of changing pollution and air quality mixture, both from kind of air pollution that the traditional air pollutants, but also climate sensitive hazards. So a key goal for my research is to really estimating associations between these kinds of climate sensitive hazards across populations, trying to understand better who and where health risks are located to identify and characterize inequitable distribution of these risks, trying to understand better how we're exposed to these hazards, and also establishing evidence to support biological mechanisms, and ultimately hoping to assist with research translation and having the research be actionable, such as, for example, quantifying the health benefits of air quality policies on the air pollution side of things. Overall, in terms of my research, the research designs and data sources that we've used have evolved over time, in part with evolving research questions. And here I'll just get into some of the designs that I've used and kind of leading up to the Envision project, which I'll use as an example to show some of our work in air pollution and health. A common design in my research has been the time series design using hospital billing records. This is a type of design where we're looking at associations between exposure and health over time, such as day to day, for a population of interest. So here we're really looking at kind of population level effects of exposures on health. And our early work, when I first joined Emory, for example, back 20 years ago, was focused really on Atlanta. Looking at the older literature, some of you might recognize our study acronym at the time was SOFIA, the study of particulates and health in Atlanta, where we looked at or collected data from local air monitoring stations that were located more in like the center of the city, and collected data on emergency department visits using hospital billing records. So billing records are really records that hospitals use to bill the insurance companies. So they have some patient level information such as age, sex, and race, date of visit, but the key thing then is the diagnosis codes that they're using to then bill the insurance companies. So we collected these data. At the time, we had to go to the triangles here are emergency departments at acute care hospitals to collect these data and do a thorough data systemization and standardization to concatenate all the data across these 40 plus hospitals. Ultimately, our data might look something like this, where we have daily levels of a pollutant of interest or an exposure of interest, could be temperature as well. Here showing ozone in black, each dot represents the day's ozone levels over a multi-year period, showing that ozone is higher in the summertime and lower in the winter. And we regress this against a health outcome of interest here, showing the daily counts of asthma ED visits in Atlanta over the same multi-year period. And so we kind of link these exposures and outcomes together using some statistical models to ultimately come up with the association between the two, controlling for things that we might think confound the association. So we have a series of papers that kind of focus in on Atlanta, but over time we've been able to expand the study to include not only Atlanta, but initially 5 cities under a kind of Clean Air Research Centers project. We were interested in expanding to other cities that might have different source mixtures. And the Clean Air Research Centers were really focused at the time on better understanding the impacts of pollution mixtures on health and ways of trying to statistically understand mixtures. And we, again, have a series of papers from there, which I won't get into today, but really more to build up to what we're currently running as an extension from these 5 cities to multiple states across the country, with the goal of recognizing that there's a lot of heterogeneity in associations across, well, depending on the question of interest, some heterogeneity, both in terms of air pollution mixtures, air quality mixtures, regional effects across our large country of the United States, where we're wanting our data to better represent these places. So we've kind of expanded from the starting study in Atlanta to a multi-state study that we've now labeled ourselves as the Environmental Exposures and Health Across the Nation, or ENVISION study. We are targeting states where we can acquire research level, patient level data on hospital billing records, really focused on emergency department visits, from states where they kind of provide and allow for these kinds of data requests. The green states are those that are in our study already, and we've acquired over, say, 400 million patient level ED visit records. And one of our goals, again, is to kind of fill gaps in our understanding of associations of environmental exposures across regions and importantly, across the full population age range. One of the key gaps in nationally representative studies to date on both air pollution and other environmental exposures is a large focus on mortality, but also the elderly through use of the Medicare data set. So a lot of studies have focused in on the data from the Center for Medicare and Medicaid Services, which is a wonderful resource for kind of administrative health resource for kind of national level studies. However, again, we're focused really on the elderly and misses a whole population of younger ages. So here, our goal is to really capture data for the full population age range, where we can kind of use these data for a variety of different questions. And we've been fortunate to have funding from a variety of different sources, largely from the NIH, but also other sources, to address various questions in both air pollution as well as climate-related exposures on health, using either all of these data or a part of these data. So I'll give some selected work, initially just air pollution as the kind of best example so far from these data on kind of a multi-location study. And then we'll get into a little bit of work on heat as well. So starting with air pollution, we've had a strong interest in ambient air pollution and asthma ED visits from our earlier work just based in Atlanta through this work through the multi-state Envision study. Asthma is one of the most common and costly diseases in the US, affecting about 1 in 12 people. And it's been linked both with, air pollution has been linked both with asthma development, so over the long term, as well as the trigger of existing asthma. And of course, linkages of air pollution with asthma ED visits may just be a marker of broader health and economic impacts, knowing that ED visits might be a little bit of a tip of the iceberg, that there's other ways that patients might be seeking care when they're having symptoms. And at the time of conducting this particular study that I'll show you the results for, the literature had a pretty big discrepancy in terms of findings as well as heterogeneity. And in the US, most studies had been limited to just a few cities or a few pollutants and restricted to either just hospitalization outcomes or just focused on like one age group. And so we know I won't actually show the results, but we know that ED visits represent a pretty significant health outcome type that's kind of missed if we just focus on hospitalization, knowing that most ED visits, especially for asthma, aren't actually hospitalized, but they're treated and then released the same day. So focusing in on emergency department visits allows us to kind of look into this broader outcome type. So this is a study then, or an analysis conducted by a prior doctoral student of ours, Zhenzhao Bi, where we, at the time, our study period was 2005 through 2014. Our data now go up to 2019 and more recent when we can. We focused in on, for the 10 states where we had data collected up until then, we focused in on the study areas around 53 pre-selected EPA monitoring stations that are identified in blue here. And we focus in on patients living within 30 miles or living in a zip code within 30 miles of these monitoring stations. There were about 3.2 million ED visit records in this particular analysis. And we linked those ED visit records with both the air pollution data at the monitoring sites, but also from a fusion model that combined ground observations with a chemical transport model simulations. The model is called CMAQ, the Community Multiscale Air Quality Model, where this fusion between monitoring data and the modeled output were conducted by collaborators at Georgia Tech. So for example, this is just the average levels in 2005 for PM 2.5 across the country. I believe these were kind of modeled at the 12 by 12 kilometer grid level, where we actually, in the end in our data, have a daily estimate for each of these grids across the country. And we see overall higher levels of PM on average in the eastern compared to western US, but of course, pockets of high pollution in the west as well. And so these data were linked at the at the location level, and we conducted basically 53 time series analyses at each of these monitoring locations, and then combined the results into a pooled national, I should say nationally representative estimate. So this is what our results looked like overall across for the whole study over this 2005 through 2014 time period. We see, for example, the PM 2.5 result here. These point estimates are rate ratios that indicate the increased rate of ED visits for asthma with each increment. Here, the interquartile range is the increment of PM 2.5. So for each 6.3 microgram per meter cubed increase in PM 2.5, we estimated a rate ratio of 1.016, which we can kind of translate into percent increases of about 1.6 to 2% increase rate of ED visits for asthma across the study. Overall, for the different pollutants, we included a couple of different PM measures, gaseous pollutants, as well as major PM 2.5 components. And we see largely positive associations, largely kind of significant at the 0.05 level. Of course, a key interest for us in this particular analysis was understanding these associations by age group to see which ages might have the greatest risk. So here showing kind of those same results, but now stratified into 5 broad age categories, including 2 kind of pediatric groups, 2 adult groups, and an elderly group. And we see largely elevated risks among the young children and adolescents, with some pollutants also showing increased risks among the elderly. And these kind of results make sense to us in some ways. We know that children just generally may be more vulnerable because their lungs and their immune systems are not as fully developed. They breathe more air per body weight than adults do, and their respiratory system is just kind of smaller, so toxicants so any inflammation that happens is maybe greater per body weight than for adults. And elderly as well, for different reasons, may be vulnerable because of compromised systems and comorbidities that might make them at increased risks for similar increments in air pollution. So this is kind of our study of air pollution and asthma ED visits. For ozone, we saw some interesting results in that they're actually not as great as for some of the other pollutants. Ozone, of course, being kind of important from a climate change and climate relevant perspective. So these results, and actually some of these a bit more muted ozone findings, we've seen in other types of studies that we've been doing of late. So that's something that we're kind of continuing to kind of dig into. But I would say kind of translating this kind of study on air pollution and health, air pollution and asthma, to the climate kind of space. One is that the kind of interplay between climate and temperature temperature, I should say, and air pollution is something that we've not done a lot of work with, but we will be moving forward. So that's one thing. And then also the multi-year data set that we've been able to acquire through the Envision project, we're starting to look at how associations between air pollution and health might be changing over time. So whether in 2005, associations between these exposures and outcomes are different than, for example, in 2019. In part, we think that policies on air quality or air pollution have reduced pollution levels, but might be changing the pollutant mix and changing pollutant toxicity. But it could be that climate-related changes are also implicating pollutant toxicity, for example, with changing ozone levels or changing PM 2.5 composition through increased secondary organic aerosols through climate-driven related factors. So that's something that in this kind of study structure we're interested in exploring, and we're doing a little bit of as part of an air pollution accountability study. with HEI, which is really focused on air quality policies, but could also be considered for in terms of like thinking about changes because of climate. So that's some of the work that we're doing in air pollution, but now I will get into some of the work that we're doing in heat, because that's also another big focus of ours, not only in this particular project, the Envision project, but also our CHART project, which we'll be getting into. So a little bit of background, which is also probably not new for you all, but heat or ambient temperatures have a big impact on health. Of course, we know that exposure to high temperatures might cause a spectrum of different heat illnesses, from just simple heat cramps to more severe outcomes that require emergency care, such as heat stroke or even death. We also are understanding that heat might affect more than just heat-related illnesses, in that there may be broader effects of heat exposure depending on someone's vulnerability factors, such as age or pre-existing conditions, including kidney disease, through and also like all the way through to mental health. Because of some prior research linking temperature with emergency department visits, we've observed pretty strong associations of heat with kidney-related outcomes. And through that initial work, we've delved into a little bit more focus on heat and kidney disease. This work is also important given that kidney disease is the burden of this is large in the US and is increasing and quite expensive. And a potential contributor to kidney-related health burdens is through exposure to high temperatures. Kidneys, of course, play a central role in maintaining the correct balance of water, minerals, and salts, and are linked to hydration, sweating, and thermal regulation. And it's highly plausible through a few different mechanisms that acute heat exposure can impact kidney health. Dehydration-related volume depletion and reduced renal perfusion may be an outcome, but also acute heat exposure could impact acute kidney injury, indicated by elevated serum creatinine levels. And I'll talk a little bit more about serum creatinine, which we're using to in some of our work, but just as background, serum creatinine is it's a waste product found in our blood through our just usual use of our muscles. So it's kind of a waste product from energy of our muscles. And the kidneys are important in filtering out serum creatinine. And so higher levels or elevated serum creatinine levels are indicated in acute kidney injury. From our work in Envision, we see, for example, across a few different cities in which we've looked at these associations, pretty strong and robust associations between elevated ambient temperatures and kidney-related morbidity, including ED visits for acute kidney injury, and as well as ED visits for fluid and electrolyte imbalance, which are kind of a dehydration-related outcome. And so we've kind of been doing some of this work using our usual hospital billing record data, but there's a few different knowledge gaps that we're also trying to fill in addition to just our work on Envision. And one is that one knowledge gap that's, I think, especially important in, for example, acute kidney injury is the reliance on ICD diagnosis coding of hospital encounters, like the diagnosis codes that we've been using in Envision may have some outcome misclassification. And also a general knowledge gap or kind of limitation of our hospital billing record kinds of data is that we really have a limited understanding of the patients themselves and the kind of identifying some vulnerable populations, and this just limits identification of opportunities for clinical intervention. So with that, we have moved, so we've kind of, in addition, and so in parallel to our Envision study, we've moved to studies that really leverage local electronic medical records. And in our case, we're leveraging data through the Emory Healthcare Network. And for this study, of course, we're focused in on Atlanta. Atlanta, of course, is our home base for Emory, but also Atlanta is quite a warm city. We know that in Atlanta we see kind of average high temperatures all the way from May through September being in the 80s. And in the middle or the height of the summer, we have at least a month where kind of the normal high temperature climbs to 90 degrees and just stays there for the month. So Atlanta's a pretty hot city. So doing work on high temperatures and health outcomes in Atlanta is an important kind of place to do it. Here we have a project where we're conducting a detailed assessment of heat and acute kidney injury using electronic medical record data from Emory's clinical data warehouse. This is a data warehouse that integrates clinical data on all patient visits at Emory's Atlanta area hospitals. And in our study so far, we have about 1.5 million ED visits. Again, we're focusing here on emergency department visits for the most part, but about 1.5 million visits made by about 600,000 patients during a multi-year period, 2013 through 2021, at 4 Emory hospitals that are captured within the CDW during this time frame. The unique part is that the data that we're able to capture using EMR is a little bit more granular and detailed than just through the hospital billing records. So for example, the unshaded rows here in this table are the usual variables that we might be able to collect from hospital billing record data, such as date of visit, some very limited demographics of patients, and of course the coding that's done, like diagnosis codes and procedure codes that are important for billing purposes. But what's missing from most billing record sources are all of the important information that might be collected at a visit. So for example, vitals, heart rate, blood pressure, labs such as metabolic panels or blood counts, and other features that might be important for really understanding health outcomes that we're then relating to environmental exposures. So here we're using these data, and especially serum creatinine that's collected through the complete metabolic panel, to better capture what we think is a community-acquired and less severe acute kidney injury that might be coded through a diagnosis code. And so in the next few slides, I'll get a little bit granular on what we're doing in that study, but just to kind of show how we're using these data to try to better understand outcomes. And we're also using these data to, for example, better information on patients' chronic conditions, their medications use, as well as more granularity in terms of street address, geocoded location of residence, where we might be better able to understand a patient's neighborhood context. That could help understand who is affected. And we're linking these data with detailed exposure modeling through a collaboration with NCAR. So one of the, I think, key motivations for this particular project was, like I'd said, better identifying acute kidney injury ED visits in Emory's electronic EMR, electronic medical record data. So here in this first paper that we've published from this particular study, we conducted a comparison of what we call ICD code-based definitions for AKI. So for example, either using just primary or secondary discharge diagnosis codes that have a code for acute kidney injury for either ICD-9 version or the ICD-10 version of coding. And comparing this with what we call the KDIGO criteria. KDIGO stands for Kidney Disease Improving Global Outcomes. It's a kind of gold standard criteria for identifying acute kidney injury. And the KDIGO criteria define acute kidney injury as an elevation of serum creatinine by at least 0.3 milligrams per deciliter compared to a baseline value. And so the key challenge for us in general is identifying what's the right baseline value to use, because everybody's serum creatinine might be different, just depending on their age or kind of their conditions. So the different KDIGO-based definitions that we've used so far really differ only in terms of our assumption on baseline values. Each of them take the maximum serum creatinine value within 48 hours of ED arrival and see whether that value is 0.3 or more milligrams per deciliter greater than some baseline that's in the crude definition. For example, there's sex-specific baselines that are just kind of published baselines for men versus for women, or baselines that are back calculated using an equation that's a creatinine equation called the chronic kidney disease epidemiology collaboration creatinine equation that involves age, sex, and an assumed glomerular filtration rate, with 90 being kind of assuming a pretty good kidney function and 60 assuming not as good kidney function. So we've done a comparison of the use of these different definitions in both capturing acute kidney injury cases in our ED visit data, as well as what the result is in our epidemiologic modeling with temperature. So here, for example, just at looking at concordance, we see that a definition involving the use of primary or secondary ICD diagnosis codes captures about 24,000 visits within the study time period here, analyzing 6 consecutive warm seasons of data, in comparison to one of the KDIGO or serum creatinine-based definitions using the CKD-EPI equation. We captured many more cases at 64,000. We also see that the concordance between these different definitions kind of differs, whereas, for example, about 90% of the ICD-coded cases are actually captured by one of the serum creatinine KDIGO-based definitions, but in reverse, only 33 or 34% of the CKD-EPI 90 cases are actually captured with an ICD code. So you probably need a little bit more time to kind of delve into this table and really kind of understand some of the differences. But overall, our finding from this one paper, which was written by one of our MPH, MD students, found that the KDIGO-based definitions captured many more cases of AKI that were really missed when relying just on ICD codes. And then when we used these different definitions in epidemiologic analyses with temperature, we found that a significant heat AKI effect continues to exist for this subpopulation that lacks the ICD codes, but are identified as being an AKI case based on elevated serum creatinine. Here, for example, just for the CKD-EPI equation, the red odds ratios shows an elevated risk for those that also have an ICD code for AKI, and the green shows a similarly elevated risk among those that lacked the ICD code. So really just suggesting that we find many more cases of AKI. They might be a little bit less severe, but they still are have a kind of a strong association with high temperatures, suggesting that the adverse effects of heat on the kidney might be more widespread than we might previously recognize using just kind of hospital billing records, and just a greater portion of the population might be affected. And that in terms of outcome misclassification, getting into some of the more granular data afforded by electronic medical records, we might be able to kind of reduce outcome misclassification and have these kinds of definitions be a complementary tool in addition to the diagnosis coding. So we have some ongoing work on different ways of exploring baseline serum creatinine definitions, including use of prior visit information from patients. That's ongoing work. And in the interest of time, I kind of see that I'm just going to skip over this part a little bit, but just to say that we're also using these kinds of data to get into much more granular information on patients. But this work that we're doing using Emory's electronic medical records really goes really into what we're also doing with CHART. So CHART is our Climate and Health Actionable Research and Translation Center, which is our NIH P20. Our vision is to become a hub that advances and translates research on climate risks to protect the health of under-resourced populations. And here we're located in Atlanta. I sit on the research project core and co-lead that core together with my colleague Howard Chang, and we work closely with the other cores of our center, including the admin core, the research and capacity building core, as well as the community engagement core. And I'll just spend a few slides giving you an overview of what we're doing within the research core. As you'll see, actually, a bulk of our data collection is happening this upcoming summer. So if you invite us back, one of us back in maybe a year and a half, we'll be able to give you actually some more results from this particular work. But I think it's important to kind of just at least introduce you to what we're doing. Our core aim is to better understand factors leading to differential susceptibilities related to heat, particularly focused on factors related to physiologic predisposition impacting heat sensitivity, as well as better understanding factors in terms of heat exposure pathways that can both help inform mitigation and adaptation strategies. Our project core is kind of divided into 3 overarching sub-aims as well as questions, with the first being who is more affected by heat-related health outcomes, the second being how are we exposed to high temperature that might lead to health risks, and then the third is what types of heat are we exposed to. And just a one-slide overview for each of these sub-aims. The first sub-aim is basically an extension of the work that I just presented on using Emory's EMR data to really delve deeply into heat and acute kidney injury. Here we're looking at a similar study design, similar study type, but extending this work to include not just acute kidney injury, but other heat relevant outcomes, and focus not just on Emory, but also on data collected from a large public hospital in downtown Atlanta, the Grady Memorial Hospital, to improve on our kind of capture of the population. And another extension of the work that I just presented is that a focus is, of course, on kind of identifying vulnerable populations and identifying kind of who the impacted populations are. And with that, we have a focus on a better understanding residential location as a, I guess, vulnerability factor, with a focus on including things like the building canopy, building type, and other building-related factors that might prove important in terms of understanding vulnerabilities. So aim 1 here is just a kind of, again, like a data analysis-based aim, and extend some of the work that we've done before, but really, we were really interested in kind of extending much more beyond just using administrative health data, recognizing that even though we're able to get a little bit more granular here with these EMR data, we are really very much removed from the patients themselves. We don't have, we might have a little bit more information on patients given the information collected at patient visits, but we don't really know who is affected and how they ended up at the emergency department on a hot day for a heat-related illness. We really don't have any information on patient context, if you will. So our second aim brings us more to the clinical space and with the ability to really connect with patients. So here, the question is, how are patients exposed to higher temperatures leading to health risks? We're conducting, we're calling a mixed methods matched case control study where we're recruiting. Our target is 200 cases that are ED visits with a heat-related illness, recruit them, and then recruit 200 matched controls, and conduct and administer a survey and a structured interview to these patients to really assess risk factors using both kind of quantitative and qualitative methods. So here, for example, when patients come in to the ED and are kind of either diagnosed or complaining of a heat-related illness, we have a clinical coordinator and a team to kind of interact with them and see if they're interested in participating, and for them to talk to us about their experience in the previous 24 hours leading up to their ED visit. And ultimately, our goal is to kind of compare their responses with those of matched control patients within the Emory and Grady networks to better understand things related to occupation, mobility, awareness, energy burden, and other kinds of factors in terms of possibly identifying risk factors and possibly identifying opportunities for intervention. And then finally, just quickly on the last aim, again, with this study, it's a survey and interview-based study. We're not doing any kind of actual exposure monitoring, but that is then covered in our third project, where we are asking, what types of heat are we exposed to? So here we're conducting a field-based study where we're recruiting 120 participants that are concerned about heat exposure, going to their homes and measuring 48 hours personal indoor and outdoor exposures to both temperatures as well as personal PM 2.5, and to kind of have a better understanding of how individuals' personal exposures might be higher or different or similar to outdoor levels over a warm summertime period. So most of our data collection on this aim is happening this upcoming summer as well. So that I will leave it at that. Some quick summary and reflections before ending. One is that air pollution is a complex and changing mixture. Policies in the US have been extremely successful in reducing air pollution levels, but despite some of that progress, we are continuing to observe strong associations of air pollution and a range of outcomes. And the extent to which this progress might be offset by increasing frequency, severity, intensity of other climate-related hazards is, starting to be possibly observed, not necessarily quantified, but the possibility that, there's some factors such as wildfires or dust storms that might be offsetting some of the progress that we've seen from air quality policies. And this idea of possibly increasing toxicity of the pollution mixture is something that we're starting to explore. And we're, in general, at least in our group at Emory, we're moving towards a better understanding of risk factors, and hopefully moving forward to evaluating interventions with this idea that, large-scale, quote-unquote, national studies have great weight in federal standard setting, but it's really also the local studies with community input engagement are important for really understanding local level impacts and also addressing questions of concern to communities. I think one of the things that there are challenges, I just skipped over a point on data access and data availability is always a challenge with epidemiologic work. I think one thing that was highlighted at the last fall, as we were coming towards the end of our initial summer of data collection as part of CHART, is this challenge of cumulative exposures, and in particular, cumulative exposures that are somewhat like unexpected and we're not prepared for. You may all have remember Hurricane Helene that caused a lot of damage in the southern US. Atlanta was also impacted by Hurricane Helene. It's hit Atlanta in September 26 to 27, had widespread impacts like Emory classes moved online, public school canceled classes, and there was also flooding throughout parts of Atlanta. Somewhat unrelatedly, a couple days later, there was a fire that broke out at a chemical facility, the biolab facility in Conyers, Georgia, which is just south of the city, just south of the metro core of the city. And it caused a huge plume of smoke. It was a fire that was very difficult to put out and was not put out for some time, some days. This was a facility that made pool cleaning chemicals. So there was this tinge of chlorine in the air that covered all of the Atlanta metro area. And this Rockdale County, in which the biolab facility was located, had a shelter in place for 19 days. Um, and this all came towards the end of our warm season. If you recall the graph that I showed a little earlier, is that our warm season extends all the way through September, sometimes into October. So it's also pretty warm during this time. And it just kind of highlighted to us that, there's these cumulative exposures that that are often kind of unexpected that we may need to consider and can somehow deal with. And there might be kind of more of these kinds of events that might take place into the future. So I don't have a great answer to that. It's more just something that's on our mind, especially as we go into our next summer of data collection in terms of what we're able to do to kind of help understand the impacts of these kinds of events. With that, I will stop, but also leave this slide up in terms of acknowledgements. I have a great core team that I work with at Emory, and a great list of collaborators at other institutions, a set of grant funding that helps support our work, as well as a growing set of community partners, especially through CHART, that is helping with the work that we're doing. And with that, I will leave it hopefully in time for some questions. I'm sorry, I went a little bit over.
Thank you very much. So if you have any questions, you could please put them in the chat. Jane, why don't you start us off?
Hi there, happy to. Hi, Stephanie, nice to see you.
Hi, Jane. Nice to see you too.
Thank you so much for visiting us today. Really nice talk. I apologize I had to miss the early part of your talk, so I don't know if this is something you spoke to before you kind of introduced us to the 5 cities heat work that you did, but I'm really curious about the idea of acclimation to heat. I find this idea really fascinating. So I'm curious about how you dealt with the concept of heat differently in 5 very climatically different spaces, different cities. And also, I'm intrigued by the idea that, a 95-degree day means something very different in May than in August because we acclimate over the course of the season. So have you thought about that at all in your work? So how are you thinking about those kind of, set points in heat, both across space and over time?
Yeah, I think that those are really great questions. I think to date, kind of pretty crudely, mostly when we're thinking about, when I presented the work across the 5 cities, that one slide, I'm pretty sure that those were thinking about quantile differences. So thinking about, some percentile difference in temperature exposures, the same quantile difference, but, every city will have its own different absolute level of temperature difference. So that is just one way of trying to make it a little bit apples to apples. But then, of course, we're missing the fact that maybe that quantile difference in Phoenix might be really different than that difference in Atlanta or, San Francisco. So I think there's there's probably maybe just different ways of presenting the results or presenting to try to get at some more nuanced questions, I think, on that. I think that's a great question. Of course, our mitigation measures are also different across these different cities in terms of air conditioning prevalence, and there's other I guess factors that go into maybe whether we do see differences across these regions or not. So, and then in terms of the acclimation within a season, so whether like a heat wave in May, the population is is maybe more vulnerable because they're less adapted to it than, for example, a heat wave that occurs in August. We've looked at that a little bit, although I feel like we haven't looked at that in detail, in part because of requiring sufficient data to be able to do that. So, you know, now that we have actually multi-years of data and also in different locations, that's maybe a question that we could come back to. I feel like in our early Atlanta work, we kind of made these indicators in the data set, but I don't think it really went far because just don't think that we had enough somehow, yeah, statistical power to really tease that out. But I know that that's out there in the literature and is something that, you know, would be interesting to look at more. That's a good question.
Well, all right. Thanks so much.
Thanks.
And we have a question from the chat next. I'll read it out loud. Thank you for this interesting talk. You saw an opposite effect by age for ozone versus NO2, with older adults more at risk from ozone, while kids were at high risk from NO2. Does this surprise you, or what do you think might explain this?
Yeah, that's a good observation. I think the results with ozone and NO2 are often curious. I think in some ways, yes, I think it would surprise me. I think one of the issues is that ozone and NO2 are usually pretty highly correlated. So when ozone goes up, NO2 goes down because that's just part of the chemical equation to when ozone is created, it's created by the reaction of nitrogen oxides with other compounds to create ozone. So NO2 often goes down when ozone goes up. So the correlation between the two is something that we should normally kind of be looking into. The differences across age in terms of which, you know, pollutant is significant for which age group. I guess that's where maybe some of the curiosity comes into play. And I think there's more that we need to do there to really tease it out. I think the difference in perhaps daily time activity patterns across different age groups could be important to think about. And, you know, when people are spending time outdoors versus, you know, other kinds of factors that might implicate their exposures. But other than that, I don't have a great answer to why that might be or how much of it might be like from our statistical modeling kind of curiosity or how we're thinking about these pollutants individually versus as a combined group. But yeah, thanks for that question. That's a good observation.
And I have a question myself here. So, you know, I don't know a lot about acute kidney injury, but you showed very low concordance between the ICD-1 and the other case definitions. And I'm wondering if you could just say a little bit more about what's happening in the emergency department that might explain this. Is this clinicians missing acute kidney injury, or do these metrics fundamentally capture a different outcome?
Yes. So, okay. So, the ICD-1 definition and the way we defined it was identifying an acute kidney injury if their primary diagnosis was an acute kidney injury. So the billing record shows acute kidney injury in that primary diagnosis spot. I would say most patients that are coming into the emergency room or are hospitalized have a lot of different diagnoses on their record. So there's the primary diagnosis, but then there might be a bunch of different secondary diagnoses. So some of the difference between the ICD-1 definition and the broader ICD definition was that the ICD definition included visits for acute kidney injury that were identified using secondary codes. So that's kind of like just by nature of the definition. But I would say the primary diagnosis code for acute kidney injury, so ICD-1, would be probably the most specific diagnosis. So we would be pretty confident that those with an ICD-1 coded acute kidney injury actually have acute kidney injury. But it's more likely that those are like the severe cases of acute kidney injury, and that less severe cases would either be put as a secondary cause, like maybe someone's coming in with a broken leg, but they also later on there's discovered they've got an acute kidney injury. It might be coded as a secondary outcome, but it might be missed altogether and might not be coded, doesn't end up on their billing record. And so that's where some of those differences kind of come into play when we're looking at a serum creatinine or what I called a KDIGO-based definition. So ICD-1, I would say, is like the most specific, but probably likely also representing the most severe cases of AKI, whereas we know that AKI, at least according to like the official criteria and definitions, has at least 3 stages. So here it's like the most severe stage AKI, and we're thinking that the serum creatinine-based definitions allow us to capture less severe AKI. So many more visits are identified than as having an AKI that are still related pretty strongly to heat. So that's where, from a burden perspective, we're capturing a bit better sense of the burden on the population.
All right, please join me in thanking Dr. Ebelt for the great webinar today.
Thank you for having me. And thanks for inviting me for your webinar series. And looking forward to connecting in the future at conferences and elsewhere.
Absolutely. Thank you very much.
Thank you.
Bye.